Hi, I'm Rui Pereira da Costa, organizer of the Endomasters 2015. For this next lecture, I'd like to present to you my friend Freddy Belliard from Dominican Republic. Although I've known Freddy in Spain, his graduation studies were in the Dominican Republic, and his post-graduation in endodontics was done at the Instituto Dr. Yuri Cutler in Mexico City. Freddy Belliard was assistant professor at Pontificia Universidad Católica Madre y Maestra in Santiago, Dominican Republic, and at the Universidad Católica de Santo Domingo. He is presently assistant professor at the endodontics specialty at Warwick University in the UK and assistant professor at the endodontics specialty at Universidad Europea de Madrid in Madrid, Spain. Freddy has also a very strong social presence in the internet, as he is forum administrator of Roots and Endo Latinos, both communities in Facebook with more than 20,000 members. His lecture is going to give us a very up-to-date perspective on the obturation of the root canal, focusing on the options we today have in this many times underestimated stage of the endodontic treatment. I'm sure you'll enjoy.
Hola Endomasters, I'm Freddy Belliard. First of all, I want to thank Rui for making this happen. It is a great honor for me to be a part of this first truly global endodontic meeting, showing that internet is very powerful and has removed the boundaries of knowledge and is opening the doors of education to everyone around the world. As a brief self-introduction, I will mention that I attended dental school in my hometown, Santiago, Dominican Republic, between years 1992 and 1997, and I also did my endo program in Mexico City at Dr. Judy Cutler's Institute between the years 1997 and 1999. Right now, I'm also dividing my time with a wonderful duty, which is being the director and administrator of Roots and Endo Latinos. These two forums have more than 25,000 people right now, all colleagues that share the passion of endodontics. But I could not achieve all these duties without my very good group of friends and fellow administrators, Rafael, Diogo, David, Ronald, Antonis, Carlos, Imran, and Bojedar. Okay, moving on. I have also to mention that my practice has been focused mainly in microendodontics and post-endodontic restorations since 1999. Yes, time flies. With no further delay, we're going to speak today about the obturation of the root canal system. Going through a brief review of its history, what our goals are, with the knowledge and technology available today, and what are our real options of achieving all these goals. Success in endodontic treatment was originally based on the triad of debridement, disinfection, and obturation, and all these aspects were treated equally. At present times, we have been seeing that we do not only speak about cleaning, shaping, obturating the root canal space, but also more care is being put into the concept of diagnosis, treatment planning, and most important, the knowledge of the anatomy and the morphology. So the better we understand the geometric implications of the areas we work with, the better we will choose our instruments, the better we will choose our materials, and most important, the techniques with which we carry out all these very complex treatments. So our clear goal is that when the time to obturate the root canal system comes, is after we have been able to shape properly, clean effectively, and have already disinfected this inner anatomy of the tooth. So the purpose of obturation is to fill all portals of exit. avoiding or impeding any sort of communication or exchange between the endodontic and periodontal environments. So by creating or making an efficient obturation of the root canal space, we not only isolate or eliminate leakage of the areas that we have managed to clean, but also we entomb the remaining irritants that can be left behind inside of the root canal system. When an impermeable seal is not accomplished by the clinician, it's not uncommon to find this muddy-like sealer and semi-solid filling material, in this case gutta percha. So the clinician has to be prepared to identify potential factors that can compromise the outcome of the root canal therapy. And such is the case of cracked teeth and vertical fractures. These conditions are often misdiagnosed and not taken into consideration, being the periodontal probe the instrument that will give us the most conclusive information. In these images is very clear the fact that on the x-rays it's not possible to locate the areas of the fracture, but the clinical observation with the operated microscope clearly show us not only the depth but also the trajectory of the crack on this molar. We can also encounter situations where the endodontic condition can be easily mistaken with a periodontal disease, as we can see in these images, or when there is a truly combined endodontic and periodontal situation. Having identified in this case that it was a primary endodontic problem with some periodontal repercussions, and also the patient was highly motivated to try and attempt this treatment, a conventional orthograde endodontic therapy was carried out in multiple sessions. And because it was accurately diagnosed and treated properly, we can see that in just 3 months the periodontal condition is indirectly healing because of the correct endodontic management of the case. We have a second set of x-rays where we can see that after 4 years the molar still is functional, is asymptomatic, even though the peripheral images or the periradicular images are not perfect. We have a perfectly functional tooth in the mouth that is giving the patient a good service. Understanding anatomy allows us to deal with challenging situations that cannot be easily observed on a normal x-ray. The clinical observation under the microscope shows that on this upper right second molar, the most difficult thing to do was to be able to address the very oval anatomy that the mesiobuccal root had. Even though we see that evolution is taking place and predictability of our treatments is improving, mostly because manufacturers are giving us a better and more reliable tools, I have to mention that magnification is opening the door to a more detailed way of interpreting even the smallest anatomy references. For example, in obturation, most of the clinically relevant assessments are better explained in some of the next 5 slides. And to show you these anatomy landmarks, I will have to take advantage of histology sometimes, scanning electron microscopy on some others, and even micro CTs. But it is fundamental to interpret and digest these references because they will impact our clinical decisions, like establishing the working length, deciding on an enlargement protocol, and even determine the amount of visits for a specific treatment. Understanding that the anatomical apex does not coincide with the physiological foramen and anatomical foramen will help us establish a more precise root canal filling limit and will push us to give more importance to the readings on an electronic foramen locator device over the information we get from an X-ray. What about our enlargement criteria? Is it based on rational thinking and interpretation of scientific findings, or are we allowing instrument manufacturers to establish these enlargement protocols for us? And believe me, there's nothing wrong with their suggestions because they know how their instruments behave and the conditions in which it will perform better. But the final decision has to come from the healthcare professional that understands the anatomic and disinfection needs. So even on canals that have configurations that are perceived as small and narrow, like this one on the image from Dr. Briseño's article, on the mesobuccal root of a maxillary molar, we will need a 25 tip file to start cutting apical dentin on this ovally shaped foramen and a 30 size file to do it buccolingually. Not only anatomy determines the size or the shape that I want to accomplish in a certain apical situation, but also the irrigation protocol could be something that determines the enlargement sizes. In my situation, because I use apical negative pressure irrigation, I will be needing to enlarge these apical thirds to at least a 35 file. This micro-CT assessment of the apical configuration of one of the teeth we have to treat most frequently clearly pushes us to realize that our choice of obturation materials and techniques need to address these irregularities in a predictable way. And these obturation materials and protocols will serve me better if they can address easily the lateral component of the anatomy that most of the times is hidden on conventional X-rays. As tools progress, and microscopes being among the most important ones, the impact they have on modern endodontics surpass the observational benefits. The quality of life of the clinician is impacted in a very positive way by the improved ergonomics associated with the correct use of the equipment, and of course, communication with the patient is enhanced. But for what I want to praise the magnification role now is for unleashing the best performance of the clinician by allowing to make the most out of newer generation instruments like ultrasonic tips, bursts, and even modifications of legacy instruments like the Muntz Discovery bars developed by Dr. John Muntz and the triple gates developed by Dr. Alexandre Capelli. What John and Alexander have accomplished is bringing back visibility to the use of instruments mounted on a contra angle by providing us with a longer shaft so the handpiece's head is out of the way. I also have to mention that the quality of the cutting surfaces of both instruments is superb. Tools are very important, especially when we face not only difficult anatomies, but also because a big part of what we do on a daily basis is retreatment. And having the proper tools will make our lives so much easier. Missed anatomy is a common finding and one of the most important reasons for root canal failure. In an article just published a month ago, on February of 2015 issue in the Journal of Endodontics, Dr. Adam Azim found out that the middle mesial canal was present in more than 40% of the cases he studied, being magnification and guided troughing what allowed these consistent findings. So in the case we're presenting on this slide, With the help of ultrasonic tips and Mons Discovery bursts, I managed to clean and remove the obstacle present on the cervical third of this molar. This allowed troughing with DG16 explorers. And with D-raised files, I removed the feeding materials inside of the canals. Patience to negotiate and instrument the root canal system was needed also. As we can see on the lower right image, even after a complete instrumentation sequence, we can find spots of filling material retained on walls and fins. I handle them usually by using flexible instruments or preventable ultrasonic tips like Irisave from Satellite or Irisonic from Dr. Alexandre Capelli. The whole shaping and cleaning is carried out, and the root canal filling is done with injection of heated gutta percha with the beta gun from B&L and AH plus sealer from Dentsply. Preoperatory and postoperatory images are shown, and it is clear that the medial-mesial canal with its independent apical foramen may have had much responsibility on the failure of the previous treatment. The patient and his immune system just need to be allowed to heal. The best way to heal is if the tooth is not bombarding the periapical tissues with bacteria and the toxins and other microorganisms from the oral cavity. After 3 months, we start seeing some healing in the control x-rays. Much is talked about biofilms. Even though many people believe that the battle we fight with it's a chemical one, it also has a very important physical, geometric, and geographic component. It is not just a matter of choosing the appropriate irrigation protocol, the concentration of the irrigation agent, but most important are the condition of the treated areas and the delivery methods we're implementing because they impact the volume and the exposure to these disinfectants. Being geometry and geography and chemical reactions an important part of the equation, it is relevant to understand that the obstacles for efficient irrigation and instrumentation are not only solid, like calcification, debris packing, irregular conditions of the insides of the root canal system, but could also be gas and liquid, like the vapor-like effect we encounter on the trajectory during the whole length of the root canal system. While the advantages of removing the smear layer may remain controversial for some, enough evidence supports its removal before obturation to allow irrigants to act on these patent dentin tubules. The organic debris present in the smear layer is a substrate for bacterial growth, and it obstructs irrigants to later on the sealer to contact the canal walls, being leakage under these conditions significantly higher than with smear layer removed before obturation. We can see a beautiful image of patent dentin tubules courtesy of Dr. Jose Antonio Figueredo. After the completion of the shaping and cleaning protocols, removal of the smear layer is generally accomplished by irrigating the canal with 17% EDTA or any of its variants, or 50% citric acid. Chelators remove the inorganic components, leaving the organic tissue elements intact. This is why we would need irrigation with sodium hypochlorite for the complete removal of the remaining organic components. In general, the aim of the root canal therapy is to remove bacteria and organic tissue from within the root canal system. But unfortunately, in seeking to accomplish this, we ourselves create an additional problem with our instrument. This is debris. Even if full rotational movements and newer generations of file designs can have improved debris channeling capabilities outside of the root canal systems, rotary NITI instrumentation actively packs isthmus areas with dentin chips. For the removal of this thick layer of debris and remaining organic tissue, not only is necessary to use the correct irrigants, but it's also the sequence and activation protocols that we implement are equally relevant. Root canals often have hard-to-reach areas that are practically inaccessible to the current mechanical preparation technologies. Nickel-titanium rotary and reciprocation techniques leave considerable areas of untouched dentin. They tend to create round preparations even in oval-shaped canals, leaving unprepared vocal and lingual extensions as well as isthmus areas without proper cleansing. Hard and soft tissue debris remaining in the root canal can compromise the filling phase. An alternative to mainstream file designs is the self-adapting file, SAF. This nickel-titanium web combines unprecedented adaptability to the root canal anatomy and simultaneous irrigation. The clinician can choose this file as an aid to his already established canal preparation protocol or as a standalone instrumentation technique. Images of the actual file are on the top right of the slide, and a comparison between canals prepared with the SAF file, images A and C, and canals prepared with rotatory nickel titanium instruments and a syringe needle positive pressure irrigation protocol can be seen also on the right. These are images B and D. This tissue debris seems to block the flow of the thermoplasticized gutta percha into these irregular and retentive areas of the root canal system. The process of cleaning and shaping determines both the degree of disinfection and the ability to obturate the radicular space. It is not possible to assess the quality of the seal established during the obturation with a radiograph, but we can sometimes deduct lack of quality of the obturation procedure with a normal X-ray. Obturation is a reflection of the cleaning and shaping, and it is evaluated on the basis of length, taper, density, level of gutta percha placement or any other type of material, and the coronal seal. So just before we enter the part of our presentation that discusses the use of materials and techniques, I want to highlight the fact that the obturation phase of the root canal therapy is fully dependent and conditioned by our diagnostic capabilities, our anatomy knowledge resources, and our clinical skills. These skills are enhanced significantly with the use of the dental operative microscope, irrigant activation methods, and the use of newer generations of instruments, materials, and techniques. Requirements of the ideal sealer for obturation are that the material should be easily manipulable with ample working time, easily mixable or better off if it's already mixed, tacky consistency that helps glide the material into the canals and be adhesive to the canal walls. It should be biocompatible, it should be physically stable, it should be radiopaque and non-staining to the tooth structure, among other properties. A quick and very brief flyover of the most popular sealers through history is shown on this slide. We will start with zinc oxygenol sealers. They have a history of being successful over an extended period of time, and they will reabsorb if extruded into the periradicular tissues. They exhibit a slow setting time, shrinkage on setting, solubility, and they can stain the tooth structure. An advantage to this sealer group is its antimicrobial activity. We will continue mentioning calcium hydroxide sealers. They were developed for therapeutic activity. It was thought that these sealers would exhibit antimicrobial activity and have osteogenic and cementogenic potential. Unfortunately, these actions have not been demonstrated. And since solubility is required for the release of calcium hydroxide and sustained activity, the benefit of having an active medicament present was defeated by the purpose of the need of having some type of impermeable seal. Glass ionomer sealers. The glass ionomer sealers have been advocated for use in obturation because of their dentin bonding properties. Ketagendo from 3M enables adhesion between the material and the canal walls. It is very difficult to properly treat the dentinal walls in the apical and middle thirds with the preparatory bonding agents to receive the glass ionomer sealer. A disadvantage also for this type of materials is the difficulty to be removed if retreatment is required. This sealer has minimal antimicrobial activity. Resin-based sealers. B&H Plus, the most popular among them, it is a modification from the previous AH26 sealer, and the difference is that the AH Plus does not have in its formulation formaldehyde. AH Plus is an epoxy resin that comes in two tubes, based in catalyst. It exhibits a working time of approximately 4 hours, and it is very easy to mix and manipulate. Silicon-based sealers. Seal from Coltene is a polyvinyl siloxane that has been reported to expand slightly upon setting. Gutaflow, also from Coltene, is a cold-flowable matrix that is triturated. It consists of gutta percha added to the Seal original formulation. The technique involves injection of the material into the canal, followed by the placement of a master single cone. This material provides a working time of 15 minutes and it cures in 25 to 30 minutes. Evidence suggests that the material fills the canal irregularities with consistency, but the setting time is inconsistent and may be delayed by the final irrigation of sodium hypochlorite. Bioceramic sealers. The bioceramic sealers are composed of zirconium oxide, calcium silicates, calcium phosphate monobasic, calcium hydroxide, and various fillings and thickening agents. The material is available in a premixed syringe with calibrated intracanal tips. It is an hydrophilic sealer, and it utilizes moisture from within the canal walls to complete the setting reaction, and it does not shrink upon setting. It is biocompatible and exhibits antimicrobial properties during the setting reaction. The manufacturer advocates expressing the sealer into the coronal and middle thirds of the canal and then seating the master gutta percha cone. Some of the requirements for the ideal root canal filling material we'll mention in the present slide. It should be capable of being fully adapted to the prepared root canal walls. It should be dimensionally stable, non-resorbable, non-irritating, be bacteriostatic, or at least it should not encourage bacterial growth. It should prevent discoloration of the tooth, and be capable of sealing canals laterally as well as apically, among many other requirements. As part of the legacy materials that are no longer in use in dentistry, we will mention silver points. They were introduced by Jasper more than half a century ago. He proposed that they should be used to obturate particularly narrow and tortuous canals, which should have been required more enlargement to be obturated with gutta percha, which in these cases always pose enormous difficulties in advancing apically. It was felt that a more rigid material than the flexible gutta percha was needed to allow it to be pushed to the desired depth. There is a manipulation and less need for canal enlargement. However, led quickly to the misuse of the material, and silver cones rapidly started to be associated with numerous treatment failures. Disadvantages of the material, we can mention that the canals are very irregular and very different from the shape of the cones. If the cones are placed beyond the apex, when the surrounding cement is dissolved, corrosion takes place and it becomes a very cytotoxic material. And last but not least, the material is very difficult to remove if the handle is not well placed or it's broken when the clinician is trying to remove the cone. Speaking about semi-solid materials, gutta percha has to come into the equation. It was introduced in 1847 by Hill, developing the first gutta percha root canal filling material, known as Hill's stopping. It is a poor conductor of the heat, so it gives us optimal control for the plasticity. At room temperature, gutta percha cannot be compressed or made to flow. Gutta percha can be made to flow if it's modified by either heat or solvents such as chloroform. This permits adaptation to the irregularities of the canal walls. The gutta percha cones are available in standardized and non-standardized sizes. The non-standard nomenclature refers to the dimensions of the tip and the body. Among the properties we can mention that it has the capabilities of adapting to the root canal system when it is heated or used in conjunction with a chemical product. It is stable in size when it cools, when it's in its beta phase. It is non-resorbable. It is well tolerated by the tissues, is radiopaque, can be easily removed in case that it is needed. It is a poor conductor of the heat and expands when heat is applied. Disadvantages of the gutta percha as a material is that it lacks the properties of adhesion to the dentin, and when the material is cooling from heat, there is some shrinkage that takes place. That is why, to compensate the thermal shrinkage, when we are using heat to thermoplasticize the material, the clinician must apply compaction forces in order to counteract this shrinking. The only disadvantage of the use of gutta percha is that being a semi-solid, or rather a semi-plastic at the time of insertion, it does not permit many errors in canal preparation. Because it lacks rigidity, it cannot be pushed to overcome a ledge or any other type of irregularity created by the clinician. So when we are starting to talk about condensation techniques, the first one that comes in mind is lateral condensation. It is a very straightforward technique and very easy to reproduce and consequently teach. The main characteristic of this technique is that a master cone should be placed with a small amount of sealer to the working length, and then accessory cones are placed by compression with a spreader between the denting and the gutta percha until a dense and well adapted mass is obtained. Being lateral condensation a cold technique, the gutta percha cones never merge into a compact mass, but the technique will always yield an obturation consisting of a number of gutta percha cones separated by a greater or lesser amount of sealer, depending on the dentist's ability. The problem with the technique is that it is easily abused by the clinician. While the spreader negotiates the space through the length of the obturation, a considerable amount of force occurs and there is an important risk of fracture. Only with difficulty can one condense several auxiliary cones next to the master cone in the most apical portion of the root canal. As a consequence, one frequently obtains an obturation performed with lateral condensation technique in the coronal 2/3 of the canal and an obturation presented by a single cone surrounded by a bit of sealer in the apical third. Especially considering that the heat is not used, the most apical portion of the master cone does not undergo any modification if it does not descend deeply with the spreader. The seal is therefore completely entrusted to the sealer, while the gutta-percha cone will serve the same function that a silver cone or a single cone of gutta-percha will have. Next technique that we're going to highlight is the warm vertical condensation. Schilder introduced warm vertical compaction as a method of filling the radicular space in 3 dimensions. Preparation requirements for the technique include preparing the canal with a continuously tapering funnel and keeping the apical foramen as small as possible. The armamentarium includes a variety of pluggers and heat source. Schilder pluggers come in a variety of sizes with an increasing diameter. The instruments are marked vertically at 5 mm intervals. Various ISO standardized instruments are also available to perform this obturation technique. So vertical condensation involves feeding a master cone short of the corrected working length, normally in a range of 0.5 to 2 millimeters short, with resistance to displacement in place. This ensures that the cone diameter is larger than the prepared canal. Non-standard cones that closely replicate the canal taper are best used for this technique, and they permit the development of hydraulic pressure during the compaction moments. After the adaptation of the master cone, it is removed and sealer is applied. The cone is placed in the canal and the coronal portion is removed with heat. A heated spreader or plugger is used to remove portions of the coronal gutta-percha and soften the remaining material inside of the canal. Touch and heat is an alternative to applying heat with flame-heated instrument because they permit temperature control. A plugger is inserted into the canal and the gutta-percha is compacted, forcing the plasticized material apically. The process is repeated until the apical portion of the canal has been filled. The coronal space can be backfilled using small pieces of gutta-percha. The sectional method consists of placing 3 to 4 mm sections of gutta-percha, approximating the size of the canal into the root, applying heat, and compacting the mass with a plugger. A variation of warm vertical compaction is a continuous wave of compaction technique. The increasing use of nickel-titanium rotary preparation techniques and the fabrication of standard cones for valves or greater taper have resulted in more clinicians using thermoplasticizing techniques. The manufacturing of cones to mimic the taper preparation permits the application of greater hydraulic forces during the compaction when appropriately tapered pluggers are in use. The technique employs an electric heat carrier, the System B unit, and pluggers that have 0.5 millimeter tips and tapers of 4, 6, 8, 10, and 12%. The electric heat source permits a variable temperature setting. The recommended temperature setting for the System B unit is 200 Celsius degrees. There is enough evidence already that demonstrates that the rise in temperature produced by these equipments and technique are within safe limits, and that is being done for a couple of decades. After selecting an appropriate master cone, a plugger is pre-fitted to fit within 5 to 7 millimeters of the canal working depth. Placing the plugger deeper in the canal may enhance the flow of the gutta-percha. The point of the plugger binding should be noticed because once the instrument reaches this point, the hydraulic forces on the gutta-percha will decrease and forces on the roots will increase. There appears to be a correlation between the depth of the heated plugger relative to the working length and the quality of the obturation and filling of the canal irregularities. The plugger is inserted into the canal orifice and activated to remove the excess coronal material. Compaction is initiated by placing the cold plugger against the gutta-percha in the canal orifice. Firm pressure is applied and heat is activated with the device. The plugger is moved rapidly 1 to 2 seconds to within 3 millimeters of the biting point. The heat is activated while firm pressure is maintained on the plugger for 5 to 10 seconds. After the gutta percha mass has cooled, a 1-second application of heat separates the plugger from the gutta percha, and this part is removed. The pluggers are designed to heat from the tip to the shank, which decreases the potential for dislodging the compacted mass and prevents a second application of heat to the material. It should be noted that the continuous wave technique, the heat source is placed only within 5 to 7 millimeters from the tip of the gutta percha. The apical portion of the gutta percha remains essentially a single cone technique, as the heat transfer does not take place in the apical 2 to 5 millimeters of the gutta percha. So one way to contrast this situation is to use a plugger that will allow us to go to within 3 to 5 millimeters of the gutta percha tip. In very oval canals, where the canal configuration may prevent the generation of hydraulic forces, an accessory cone can be placed alongside the master cone before compaction. With type 2 canals, the master cones are placed in both canals before compaction. A hand plugger is used to stabilize the cone in the canal, while the other is being obturated. Filling the space left by the plugger can be accomplished by the thermoplastic injection technique of gutta percha. Heating of gutta percha outside of the tooth and injecting the material into the canal is an additional variation of the thermoplastic technique. The Obtura 3, the Calamus, the Elements Obturation Unit, and the Beta Gun from B&L are examples of available devices. These two cases are a clear example of the benefits of using a technique that makes the most out of the properties of current materials, such as the hydraulic flow of the cement and the adaptation of the semi-solid material, in this case gutta percha, to seal the anatomy of these complex and irregular root canal systems. On this molar, for example, if we focus on the images on the X-ray, we will see that the canal do not seem to be very oval, but in the clinical picture on the top right, we can see that we managed to fill the entire shape of the canal with the gutta percha without having to rely too much on the cement. A very interesting approach to the thermoinjection techniques is the one proposed by Dr. John Stropko. It is the System S technique. The System S does not just only refer to the injection of thermoplasticized gutta percha, but rather to a specific protocol to maximize the three-dimensional sealing of the entire canal system. There are 6 important components of the System S technique. The first of them is the proper shaping with patency. The second component is adequate cleaning and drying, then delivering of the pre-warmed gutta percha to the apex. The fourth part is the coronal seal of the rest of the system, the respect for the endo and prosthodontic relationship, and last but not least, the use of the operating microscope for the entire endodontic procedure. So about the shaping and patency, we should say that the apical terminus of the canal should be kept as small as practical, and patency must be maintained during the whole procedure. Irrigation is used between each instrument during the entire shaping process, and patency is continually checked with a 10 file. Note that the volume of irrigants is probably the most important of things. Delivery methods that augment the volume of irrigant flowing to the whole length of the canals should be considered. One good example of this type of systems is negative pressure irrigation with the endovac that guarantees at least 3 millimeters of irrigant within the working length. Another addition to the irrigation protocol that will ensure a desired lateral flow of the irrigants and in the implosion necessary to facilitate biofilm disruption is the activation with an ultrasonic device. During the shaping process, final cleansing can be effectively accomplished by the alternate use of sodium hypochlorite solutions, 17% aqueous EDTA for approximately 30 seconds to 1 minute, and at least 1 milliliter of this solution. And again, some irrigation with sodium hypochlorite to disinfect and stop the action of the EDTA. For the delivery of the preheated gutta percha, when the canals are well dried with the help of the ethanol, the suction with the capillary tip, and the paper cones, the cement is applied on the walls to create a coating effect similar to when we applied a coat of painting on a house wall. Using short and rapid movements, the walls of the canal are completely coated with the sealer. The use of the operative microscope is a great aid to observe when the coating of the canal by the sealer is complete. Then a clean absorbent point is used in the same manner to remove any excess sealer. Only a thin coat of sealer is necessary to act as a lubricant. One of the most common mistakes made by the clinicians is the use of too much sealer. When this situation happens, the clinician should remove the excess sealer with other paper cones. This technique is not sealer dependent and uses the sealer as a lubricant to facilitate the flow of the gutta percha while injecting it into the canals. The size of the needle used and the delivery equipment could be ranging from a size 20 to 23 gauge. It is generally a matter of preference, and it depends on what the canal wants. It does not make any difference in the scheme of things how far apically into the canal the needle is placed, as long as it is not binding. The straighter and larger the canal is, it can take a larger needle. If the canal preparation is narrower, then a narrower needle will be needed. The needle is then placed as far as it will go apically into the canal, just short of binding. If we come to a point where the file binds, we should retract it at least 1 millimeter. Obturation is accomplished by filling the canals in a rapid succession to the desired level in the orifice. Then immediately proceed with a pre-measured plugger to create more hydraulics, deep packing, and start the compaction process. Since the softness of the gutta percha is mass dependent, the gutta percha at the orifice has the greatest mass and will stay softest for the longest time in the canal. The plugger should be firmly pushed into the soft gutta percha and held at the measured depth for just a few seconds to achieve compaction of the gutta percha on the apical third. It has to be noticed that since the professional has to overcome sometimes a difficult learning curve to adapt this technique to the majority of the cases, the meaning of the forces applied and other clinical situations tend to change from one clinician to the other. And the last parts of the sequence on the System S techniques are the coronal seal for the rest of the system. When the person that has done the root canal treatment is the same person that is going to do the build-up, this would not be a problem. But in such cases where the patient has to go back to his general dentist to do the build-up, even in those cases we can establish an impermeable seal of the orifice of the canal. In this case, you can see how we used a flowable composite. In this case was a Permafold Purple from Ultradent. When it comes to the relationship between endodontics and prosthodontics, we should determine which is the person that is going to be ideal to carry out the build-up of the case. In most of the situations, the expert in the canal configuration is the endodontist, and since this clinician has the patient already isolated with a rubber dam, the patient is already anesthetized and ready, it would be advisable to perform the reconstruction of the endodontically treated tooth in the same appointment, and this could prevent cross-contamination after the root canal procedure is done. And as you have been able to see in the whole presentation of the case, the operating microscope has been one of the main components of the technique. Continuing with the obturation techniques, we will mention carrier-based systems now. Thermofill was introduced as a gutta-percha obturation material with a solid core. It was originally manufactured with a metal core and a coating of gutta-percha. The carrier was heated over an open flame and introduced into the canal system. This technique was very popular because the central core provided a rigid mechanism to facilitate the placement of the gutta-percha inside of the root canal system. Advantages included ease of placement and the pliable properties of gutta-percha. Disadvantages were that metallic core made placement of a pulse challenging, and retreatment procedures were difficult. In addition, the gutta-percha was often stripped from the carrier, leaving the carrier as the obturating material in the apical area of the canal. Changes performed in the carrier systems include the development of a plastic core coated with an alpha-phase gutta-percha and a heating device that controls the temperature. Obturators are designed to correspond to the ISO standard file sizes and some commercial nickel titanium prototype file systems. Size verifiers are available to aid in the selection of the appropriate carrier and should fit passively at the corrected working length. The latest changes in the system is the implementation of a gutta-percha core. This is done by a process called cross-linking that connects the polymer chains and transforms the gutta-percha to make it stronger, while retaining the capabilities and the properties of the gutta-percha. Thermomechanical compaction of gutta-percha was first described by Dr. Max Baden in 1980. This involved the use of the Max Baden compactors, which are stainless steel inverted headroom files with a 2% taper. In this technique, the use of Max Baden's compactors at 20,000 RPM produces friction between the gutta-percha and the internal walls of the root canal, leading to the thermoplasticization of the gutta-percha. The gutta-percha is moved apically and laterally due to the orientation of the blades of the Max Baden compactors. A modification to the original technique introduced by Dr. John Max Baden was published last year in the Journal of the South African Dental Association by Dr. Imran Qasim. In this technique he proposes, he uses a reciproc file R25 to gain the benefits of thermoplasticizing the gutta-percha. The use of reciprocal endodontic instruments in the thermomechanical compaction during obturation has not been previously described in the literature. The reciproc file system was developed by Dr. Ghassan Jared and launched in 2011. This system consists of 3 files, but the file that is going to be used on this modification of the thermomechanical technique is the R25, which has an ISO tip size of 25 and 8% taper at the apical 3 mm. These files are manufactured from M-wire, which has been shown to be more flexible, stronger, and more resistant to cyclic fatigue compared to traditional nickel titanium instruments. The cross-section of the files is S-shaped for greater flexibility, more efficient cutting, and channeling of the debris. The blades are non-landed and are designed to cut in a counterclock direction with asymmetric reciprocation motion. This is exactly what makes possible the use of this instrument on a clockwise motion to push the gutta percha into the canal system, performing similarly to the max pattern obturators. This technique modification might come very handy as a money-saving alternative since we could use the already ready-to-discard instruments. They do not have to get too deep inside of the canal system, and the risk of engaging and breaking them is minimal. So I will just mention some important guidelines for the use of the reciproc files for thermomechanical compaction. First, we need to have a straight line access to the coronal third of the root canal. The taper preparation required for the use of this instrument is a minimum of 6% and a size tip of 30. The gutta percha points that are going to be used here should be at least 4% taper. And it is essential to confirm that we have a firm tuck back when the master cone of gutta percha is placed inside of the root canal system. A minimum amount of root canal sealer should be used. The gutta percha cone should be cut at least 3 to 5 millimeters above the orifice level. The file should be used in a contra-angle handpiece inserted into the gutta percha cone and used at 20,000 RPM. The file should be inserted to a depth of only 5 millimeters beyond the orifice, which can be pre-measured, and a rubber stopper should be used. The duration of the compaction should be a maximum of 5 seconds. In novel canals, or when one gutta percha cone is used, a slight pumping and lateral motion can be used to compact the gutta percha cones. The rotating file should be moved along the outer wall of the canal. And finally, a gutta percha plugger, for example a Mach 2 plugger, can be used to vertically condense the plasticized gutta percha mass. The final obturation technique we're going to speak about today uses bioceramic sealers. We need to understand the advantages of bioceramics in dentistry and why they have become so popular. The reason is related to their physical properties. Bioceramics are biocompatible and osteogenic, non-toxic, they do not shrink, and are chemically stable. For clinical purposes in endodontics, there are many advantages of using a premixed sealer, being the main one of them the ease of use. In addition to a significant saving of time and convenience, one of the major issues associated with the mixing of any cement or sealer is an insufficient and non-homogeneous mix. A further advantage of the material itself is its ability during the setting process to form hydroxyapatite and ultimately create a bond between dentin and the filling material. A significant component of improving the adaptation to the canal wall is the hydrophilic nature of the material, using the moist of the canal walls to assist in the setting process. Bioceramics have a high pH, 12.8, during the initial 24 hours of the setting process, which is strongly antibacterial. They have enhanced biocompatibility, they do not shrink or resorb, which is critical for a base sealer technique. They have excellent sealing ability, they set quickly between 3 and 4 hours, and they are easy to use. On this video, courtesy of Dr. Gilberto de Bellian, we're going to see a sequence of the use of the bioceramic sealer and the bioceramic coated gutta percha cones. we can see the capillary tip being mounted on the syringe. It is introduced inside of the resin block, and we can see how the material flows into the canal. The tip is removed, and some of the remaining sealer that is inside of the capillary tip is used to be pushed into the canal system with a lentulo. After the whole length of the canal is fully coated with the bioceramic sealer, with a little bit of bioceramic sealer, we glide the gutta percha cone inside of the canal and seat it at the working lid. We cut the gutta percha with a heat carrier and compact with a hand plugger. Now, to bring this same procedure into clinical conditions, we will see how we push the bioceramic cement into the root canal sealer of the first lower molar. And as you can see, it is a really easy and straightforward sequence. The one clinical recommendation that I would give is that in order to push the cement into the canal, we make sure that the capillary tip is not binding into the canal. We should make sure it is free and it's flowing in and out at the moment of pushing the cement inside of the canal. I have to remind all of you that this would be a seal-based obturation technique with a single cone approach. These are the mesial canals that have been obturated already, and you will see that the distal canal has a very oval shape. So we chose, after pushing cement into the canal, to place more than one cone. If it's needed to perform a retreatment, we should make sure that when we make the obturation, the master gutta percha cone reaches the working length. If this is the situation and a case has to be retreated, the gutta percha cone will serve as a guide through the material, and the complete removal of the obturation should be something not too difficult to perform. After the 4 cones are in place, with a heat carrier at the orifice of the canals, the gutta percha is cut and then plugged slightly. And now some cases where we obturated the canals with the bioceramic sealer and the bioceramic coated gutta percha cones. We can see in this premolar that we have some lateral and apical puffs. This is not the intention, but it's a consequence of having patency during the whole procedure. In our last case, it is a second molar, and as we can see on the apical third, we benefited a lot from the easiness to obturate the irregularities, specifically on the apical third of this mesial root. So this is the end of the presentation. It has been an honor to be here, and I want to thank Rui and all the people present, and I hope you enjoy the rest of the Endomasters. Good night.